Hello, and welcome everyone to poster lightning session, examining health at the intersection of biology, environment, and identity. I'm Dr. Erica Landis. I am the branch chief for innovative collaborations and ancillary studies or partnered research studies at All of Us. Before we get started, I want to share some brief housekeeping notes. You can go to the next slide. Closed captioning can be turned on by presenting the CC icon above the video on your screen. If you run into any technical issues or need an accommodation, please email all of us Science Day at pixispartners.co. Next slide. To ask a question, select the Q&A option at the top right of your screen. Type your question and submit it. Questions submitted through the chat box will not be monitored throughout today's session. So please use that Q&A box to ask your questions, and those will be answered. I'm delighted to introduce our panelists. Please join me in welcoming Yi-Ting Lin as a graduate student from Johns Hopkins University School of Medicine, Trisha Ganu, a recent graduate of Washington University in St. Louis, David Zhao, who is a data analyst at the University of Miami, Yash Kadakia from the University of California, Irvine, Ivy Lung, who is a pre-doc, a graduate student from the University of Mississippi, and Vincenzo Melo, a graduate student from the University of Washington. All presenters today will be focusing on examining health at the intersection of biology, environment, and identity. During this session, our first three speakers will present, and then we'll have a Q&A before our final three speakers will present, and then we'll wrap up with another Q&A for those last speakers. We'll begin today by sharing a pre-recorded video from Yi-Ting Lin, who unfortunately was not able to join us.
Hi everyone, my name is Yi-Ting Lin and I am a first-year medical student at the Johns Hopkins University School of Medicine. Today I am happy to share my research titled Racial and Sex Disparities in the Timeline of Cardiovascular Complications Among Patients with Psoriasis, a longitudinal analysis of the All of Us research program. So for some background, psoriasis is a systemic inflammatory disease. And beyond the skin, this chronic inflammation drives significant metabolic and cardiovascular comorbidities, significantly increasing the risk of major adverse cardiac events. While the association is known, this temporal trajectory or lead time from skin diagnosis to major cardiac event remains poorly characterized among diverse populations. Currently, we lack a clear understanding of how biological factors and social determinants of health interact to drive these outcome disparities. Clarifying these timelines is important for developing screening guidelines that can intervene before inflammation advances to irreversible cardiac events. Our objectives were to quantify the incidence rate and median time to onset for a composite major cardiac event and to determine if racial identities and sex independently predict a significantly compressed timeline to these complications. We used the longitudinal power of the All of Us research program to conduct a retrospective cohort study of 8,650 adults with new onset psoriasis and no prior cardiovascular history. Our primary outcome was time to MACE, defined as myocardial infarction, stroke, heart failure, unstable angina, and cardiac arrest. We constructed multivariable Cox proportional models to estimate adjusted hazard ratios controlling for age, sex, race, BMI, insurance status, and baseline comorbidities. And Figure 2 here shows the adjusted hazard ratios for MACE for the variables that were significant. So for our key findings, over the 74,272 person years of follow-up, 596 MACE events occurred. Our data reveals a disparity that Black patients exhibited the highest incidence rate at 15.5 per 1,000 person years compared to just 7.12 in white patients. In our fully adjusted models and Kaplan-Meier curves shown in Figure 3, Black race remained the strongest predictor of accelerated cardiovascular onset, with an adjusted hazard ratio of 1.71. Hispanic ethnicity and multiracial identity also had significantly higher risks at 1.31 and 1.51 respectively. Male sex was also associated with increased risk compared to female. And for other factors such as Medicaid insurance, it was also a predictor of MACE with an adjusted hazard ratio of 2.08, doubling the risk compared to private insurance. This suggests that our publicly insured and minoritized patients, the transition from skin disease to heart disease is happening at a significantly accelerated rate. So for implications, these findings bring awareness to the shift from age-based to risk-stratified cardiovascular monitoring. Because this compressed timeline persists independently of traditional risk factors, it suggests a synergistic relationship between systemic inflammatory burden and race-specific stressors. This study advances the All of Us mission by leveraging diverse longitudinal data to uncover health disparities. And these findings support equitable preventative care to ensure that patients receive interventions before their disease trajectory becomes irreversible. Thank you.
All right, thank you to Yiting Lin for taking the time to record her presentation and share it with us today. Up next, we have Trisha Ganu.
Hi everyone, my name is Trisha and I'm a recent graduate at Washington University in St. Louis with a degree in neuroscience, and this project comes from my work over the past 2 years with Williams & Associates, Inc., which is a St. Louis-based organization focused on addressing disparities in care. I also want to acknowledge my mentors, Dr. Jonathan Williams and E. Rice Williams Jr., who've really guided me in community-based research and understanding these issues at a local level. Through this work, we've been investigating HIV-associated seizures, specifically looking at their prevalence and how they differ across populations using both national and local data. So from here, I want to hone into some main aspects of our project, like key findings and future implications. So to start off with some context, HIV is still a major global public health issue affecting tens of millions of people worldwide. And one complication that doesn't get talked about as much is seizures. About 11% of people living with HIV experience seizures, which is dramatically higher than what we see in the general population. These seizures are also linked to worse outcomes, including higher mortality. At the same time, we know that HIV itself disproportionately affects certain communities, particularly Black Americans. And this is especially relevant in the St. Louis area, where Black residents make up a large portion of the population and are heavily impacted by HIV. Despite this, there hasn't been a lot of work using large representative datasets to look specifically at seizure risk in people living with HIV, especially at the local level. So overall, there's a gap in understanding both the clinical burden and how it's distributed across different racial groups. So with that in mind, this project had 3 major goals. First was to figure out how common seizures are among people living with HIV in the large national data set. Second was to look at how that burden is distributed across different racial groups. And third, to see whether we observe similar patterns in a local patient population here in St. Louis. To answer these questions, we used 2 different data sets. The first was the All of Us research program, which was the large national data set. And within this data set, we identified 2 groups using diagnosis codes, one group with seizure disorders and another with HIV. Then we looked at how many individuals fell into both groups, and we broke down all of these results by race to better understand disparities. To complement this, we used a similar approach using a local data set from a WashU outpatient infectious disease clinic, looking at patients treated over a 3-year period. This allowed us to compare national trends with what we're actually seeing in a real clinical setting. And to move into results, in the national data set, a little over 10% of people with HIV also had a seizure diagnosis. And when we looked more closely at who was affected, nearly half of those individuals identified as Black, which is much higher than what we would expect if the burden were evenly distributed. We saw a similar pattern in the local data set, where about 8 to 9% of patients with HIV had seizures, and Black patients again made up a large proportion of those who were affected. Taken together, these findings suggest that seizures are relatively common among people living with HIV, with a disproportionate impact on Black patients across both datasets. It's also important to recognize that both these datasets rely on individuals engaged in traditional healthcare systems, so they may not fully capture those facing barriers to care. Looking at this within a dataset like All of Us, however, which was designed to include more diverse and historically underrepresented populations, definitely helps bring these differences into clearer focus. From a public health perspective, this also points to the need for more targeted and community-engaged approaches to better understand how these conditions intersect, especially in high-risk communities, which can in turn help guide interventions that improve awareness, reduce disparities, and support more equitable care. And is there any questions?
Thank you, Tricia. As a reminder to everyone, if you have questions for Tricia, please put those in the Q&A box on your screen. Up next, we have David Zhao.
Hello everyone, I'm David from the University of Miami School of Medicine. So one of the main conditions our group is interested in is called rheumatoid arthritis, short for RA, which is a chronic autoimmune disease characterized by systemic inflammation that primarily affects the joints. Prior studies have associated air pollution to RA, but most of them focused on environmental exposure alone and often lack the use of nationwide US data. And few of them integrate the combined effects with genetic and other clinical risk factors. Therefore, the goal of our projects is to identify first key risk factors and their association with RA, and second is trying to develop a comprehensive R risk prediction model that will integrate all of these factors. Could you go to the next slide, please? So in this is the method we use. We quantify the genetic risk using something called the polygenic risk score, PRS. This is from prior established studies. This is like a single score numeric that kind of combines different genetic variation. The higher the score means the higher the risk. And then for clinical risk factors, we use joint pain, and for environmental exposures, we grab the annual concentration of these different pollutants from an external data source. For data processing, we make sure that we're only dealing with incident RA cases and not prevalent cases. And we start following those participants from the baseline till their first RA diagnosis or loss to follow-up or being censored at 10 years. Below, we have our cases and controls definitions. And for analysis, we use two parallel methods. The first one is called lasso and elastic net, where we select the more important variables and the less important variable kind of get drops. Another method is called the extra boosting method. This is a machine learning method that kind of predicts our risks for each individual. And what we do is that we take the risk for individual and we rank them from smallest to largest and group into the three different groups. So the first tertile is the lowest risk group and the third is the higher risk group. Could you go back to the previous slide, please? So in the results, our cohort included over 64,000 participants, about 0.5% developed RA over 10 years of follow-up. In table 1, we show the hazard ratios of risk for RA of only the significant risk factors. So we do see having a higher PRS, the genetic risk, having a joint pain, and having been exposed to higher concentration of carbon monoxide are all associated with a higher RA risk, whereas having a higher temperature is slightly associated with a negative RA risk. So now that we have our model, how do we evaluate how good or how well it performs? So in table 2, we show the area under the curve, which is the IUC of different models. So the higher the scores means the better separation between the case and controls. So we do see that with demographic only, and if we go up the ladder, if we include both the PRS and air pollutant, which is genetic plus environmental, we do see a higher IAUCs. And in figure 1 below, this is used in the tertiles we created earlier. And the interpretation of this, if you look at the yellow bars, which is the test data evaluations, if someone is being put into the second tertile, which is the median predict our risk group, you see the risk for I is actually 2 times than if you're put into the first tertile, which is the lowest risk group. And if you're put into the third tertile, which is the highest predicted risk, the risk for I actually is 5 times higher compared to the first tertile, which is the lowest group. So this kind of composite score may help us identify high-risk individuals, and this may aid clinicians for prevention and early interventions. For some future directions, we would like to examine additional risk factors like HLA and other lab measurements, evaluating alternative machine learning methods, and we would like to validate it using an external data set to kind of develop a more generalizable model. And eventually, we're hoping to put all this together to construct a risk table that would help clinicians identify high-risk individuals and support the intervention. We gratefully acknowledge all of our participants for their contribution and for the research program for making this data available. And we also like to thank the unsupported support from the Star Family Foundation and the U.S. Environmental Protection Agency for providing the air pollutant data. Thank you for your time.
Great, thank you, David. I'm now going to invite David and Trisha back to the virtual stage for our first Q&A session. If anyone has questions for David or Trisha, please put them in the Q&A box on the right-hand side of your screen. I will start by taking advantage of my position as moderator to ask you a few questions myself. Trisha, I'm curious, in your experience exploring the All of Us data set, what other identity data types, like social determinants of health or demographics, would you be interested in looking at or may have already analyzed that might impact seizure activity for people living with HIV?
Yeah, as of now, we just mainly looked in terms of like race, ethnicity, and age, but definitely in the future, we could look into more like socioeconomic status and other systemic factors that could also contribute as well.
Thank you. And David, you mentioned using other data sets to validate your results and create a more generalizable model. What other data sets are commonly used in the field, or what would you be looking for to evaluate potential data sets to use?
Yeah, so what we're planning to do, because now that we have our model, is we're trying to replicate using the same model, but put that into a different data set. So some of the, it depends on the collaboration we have right now and the grants we're applying to. So we're looking to get involved with other public available data, such as Florida, and also there's the VA hospital data that we're aiming to, because they also have their own unique set of pollutants that will be available to use. So that will also add more information to our model. Yes. Thank you.
That's great. Thank you. And I'll give a quick plug on behalf of all of us that we are actively looking at adding new environmental data to our data set as well. So hopefully that will be something, something for you to work on in the next couple of years. So we do have one question from the audience, and I think this is for David as well. Did you explore any interactions, such as using SHARP, etc., between genetic and environmental features for rheumatoid arthritis?
Yeah, that's a really good question. So we're actually aware of, it's not only between the genetic and the environmental, so even among the pollutants, there are like a lot of interaction as well. So we actually did like a heat map, and then as you mentioned, like not a SHARP thing, but we did check the interaction beforehand. So all of the pollutants we put in are already pre-filtered without like a huge interaction effect. And it also goes back to the method we use. So the lasso and elastic net kind of deal with that interaction inherently. So the model would actually reduce the effects of related variables and select the more important ones in the final model output. So this kind of is being taken care of. And I think that's the beauty of using a machine learning model, because it kind of like deal with that internally. But that's a really good question. Yeah.
Thank you. And back to Trisha, does your analysis of All of Us participants and local participants from the other data set reflect what you might see in other populations, either across the United States or internationally?
We haven't looked at other states as well, but in the past we have done like surveys in the St. Louis area that kind of confirm some of these same findings. And in regards to your previous question, I also wanted to mention that in the future, we hope to look more into factors like an area deprivation index to kind of look at those geographical factors that might contribute as well.
That's a good idea.
Definitely, I think that could give us some information to see if this same trend is kind of replicated across the US.
I love the idea of combining local data sets with national data sets like All of Us. I think that's a really exciting opportunity that people have with All of Us and other large data sets around the country. For both of you, and we can start with Trisha, what motivated you to look into these topics for your research?
I've always been really passionate about health equity, and knowing that HIV is such a prevalent issue amongst these communities in the St. Louis area, I think really motivated me. And the organization I've been working with, Williams and Associates, has been doing this work for a while now. So it just made me really interested to kind of learn more, especially into the intersectionality of the issue.
For me, so the first region is this project is collaborating with the Rheumatology and Immunology Department at the University of School of Medicine. So both of our group are actually very interested in trying to push for a model that will really help our collaborators, clinicians, researchers to kind of have early, risk prediction for them so that they can kind of bring down, because there are a lot of tests, lab results you need to run to identify those. So we're thinking if we could have really, something to start with for clinicians, it would save a lot of time and, provide guidance for early interventions. Yeah.
That's great. Thank you. We have one more question from the Q&A, and then we're going to move on to our next speakers. And this is for David. An audience member noticed that you only have 364 cases. When you perform the XGBoost model, did you use a specific tuning method?
Yeah, so for the tuning methods, we actually run the XGBoost model using the Python. So I don't have the specific details of the tuning parameters at hand, but yes, we did tune a lot of I think it was the score we use is called the F1 score. So that's the main matrix we use to kind of to capture that kind of imbalance classes we have, because we do have pretty low prevalence for this conditions, and this condition actually match to what you expect in reality. So this is kind of a rare condition. So it's about 1% in the general population. So that's a really good question. So we're trying to capture that where we're modeling. We do take that imbalance class into account. So we tried actually different things. We use like F1 score, and then there's some other metrics that we use. It's actually a list of different variables or parameters that we're tuning.
Thank you. And thank you both for your presentations and for answering some questions today. We're going to move on to our next three poster presentations, starting with Yash Kadakia.
Hello, my name is Yash Kadakia, and I recently graduated from the University of California, Irvine just a few weeks ago. And today I'm going to be presenting on changes in total sleep time and REM sleep following surgery for benign prostatic hyperplasia, evidence from wearable device data on behalf of the Department of Urology at the University of California, Irvine. I know that was a whole mouthful, so let me kind of break it down. So benign prostatic hyperplasia, also known as BPH, is a non-cancerous enlargement of the prostate that can obstruct urinary flow and cause lower urinary tract symptoms, also known as LUTS. BPH commonly leads to issues such as nocturia, which disrupts sleeps and reduces overall sleep quality. So we wanted to basically look at the connection between a urological condition and sleep. And specifically, we wanted to look at total sleep and also REM sleep, also known as rapid eye movement sleep, which is honestly probably one of the most crucial sleep phases. There's 4 total sleep phases, and this is probably the most crucial one in terms of how restorative it is, how important it is for cognitive purposes and emotional purposes as well. And for BPH, there's a wide range of therapies, but we wanted to look at 2 main surgical interventions known as TURP and HOLEP, which both are known to improve urinary symptoms, but their effects on objective sleep outcomes have not really been studied, which is why we really wanted to use this All of Us database to kind of look at this. But before we dive into the data and what we found, I do want to give a brief breakdown on what the prostate is and the surgical interventions associated with BPH. So the prostate is a male reproductive organ, and it's almost the size of a walnut. It's not that big. And what happens, what the function of the prostate is, it basically nourishes and protects the semen before it is ejaculated later on. But basically, the prostate, it surrounds the urethra. The urethra goes through the prostate. And what happens is when the prostate enlarges, it squeezes on the urethra. And the function of the urethra, it has 2 main functions. Urine travels through it, and for male semen also travels through it, the same pathway. So what happens is when the prostate is enlarged, it compresses on the urethra. And this makes it difficult to urinate. You have symptoms such as urinary incontinence. You have to keep waking up at night, which are all associated with nocturia, which affects sleep. And sleep is obviously known to affect so many different areas of our life. So now explaining that, I want to discuss a HOLEP and TERP a little bit. So HOLEP is I would say it's a neurotherapy, it's a neurosurgical intervention. And essentially what happens is the surgeon, they go in with a laser, and with the laser, they essentially remove the obstructive prostate tissue, which helps restore normal urine flow. But this is mostly for larger prostates, prostates that's gotten really, really big. TERP is a different therapy where they go through the urethra, they use a recetoscope, and they essentially chip away at the prostate. So this is a more traditional therapy, and it's been used a lot longer. But this is not for prostates that are too big. I would say this is for more moderately medium-sized prostates. Now, explaining that, we basically use our data came from the All of Us database, the Control-Tier V8 database. And we defined a few different cohorts using concept IDs. We had a cohort which was just no surgical intervention. We had a TERP cohort, a HOLEP cohort, and then a cohort where we just combined the data from TERP and HOLEP. And then we looked at three main outcomes: total sleep duration, REM sleep duration, and then the proportion of REM sleep over total sleep. And then we used a few different analytical approaches to look at the data in different angles. But what we essentially found was that surgical intervention actually led to longer sleep times than conservative management. It also led to longer sleep times than conservative management. But when we did our different types of analysis, our record level analysis led to there being a significant result, while participant level analysis led to there being a non-significant result. But yet the direction across all the trends was the same. And I think this shows that there is definitely a connection that needs to be studied a little bit more. I think we would definitely want to do a study again where we could look at race, ethnicity. We could hopefully improve our statistical power a little bit, have more patients in our pool. I think that would be very helpful. But longitudinal studies evaluating pre and post surgical changes in sleep in the same patients could also be very insightful, because then you could see that, hey, does this surgical intervention lead to direct improvement in the same patients? But thank you so much. Thank you to the All of Us database and the NIH for hosting this amazing program. And I'm open to any questions later on during the Q&A session. Thank you.
Thank you, Yash. Next up, we have Ivy Long.
Good afternoon, everyone. So I'm Ivy, and I'm currently a PhD student at University of Mississippi, and I do health service research and policy research, mainly around women's health and opioid use. So today I'm really happy to share our work on contraceptive use among young women after a cancer diagnosis. So in more simpler words, we wanted to understand how birth control use may change after a young woman learns that she has cancer. So cancer survivorship is about much more than just treating the cancer itself, especially for young populations. Here, I refer to those aged 18 to 39. It also includes helping them manage everyday health needs and future life decisions. So for young women, that would include reproductive health, pregnancy prevention, and family planning. And national data tells us that many young women in the United States have already been using some form of contraceptions, mainly birth control pills. But the use among cancer survivors may be lower. And much of the earlier work actually focused mostly on gynecological cancers and with a very wide range of survivorship duration. So we want to ask a very straightforward question here. After a cancer diagnosis, regardless of any type, how does birth control use change? So, of course, to answer that question, we use data from the All of Us research program, and we use the survey data and EHR data. And we include females aged 21 to 35 who were first diagnosed with cancer between 2017 to 2022. And we also compared them with a group of females who didn't have any cancer diagnosis during the same time period. And for contraceptive use over time, we look at the use 12 months before and after cancer diagnosis. We examine two main buckets of contraceptives. That is Plan A and Plan B. By Plan B, I'm referring to emergency contraception. And by Plan A, that will include several different types. That includes the pill, IUD, and also the ring, which is intravaginal contraceptives. So here's the results. So in the final sample, we have 1,855 young women with cancer were included in the cancer cohort, and around 24,000 women without cancer were included in the comparison group. The largest proportion of cancer cohort were white, never married, and had a family history of cancer. So what the results suggest is that there may be a small jump in birth control use around the time of diagnosis, as you can see in the graph on the left-hand side. Although it's not really statistically significant, but there's still a small jump. And a clearer pattern can be observed afterward. That is, birth control use showed a monthly decline after diagnosis. And similar patterns can be observed for emergency contraceptive use. And if we look closer to the table on top, we can see that the patterns of use for different types of birth control also vary. So what we find, it does not necessarily mean that young cancer survivors are not interested in contraception. We suggest a few possible explanations that would include greater awareness of pregnancy prevention when they find out the diagnosis. And after diagnosis, they may exhibit voluntary childlessness, and that also translates to lower sexual activity. So there's no need for contraception. At healthcare system level, there may be some barriers to access because some of these birth controls will require prescription or interaction to healthcare provider. And also that may also reflect some limited education and counseling about birth control. So the value of this work can also be further extended by involving the voice from cancer survivors and oncologists to see how they actually choose, use, and access birth control overall. As reproductive and sexual health are key components of survivorship among young population, this type of support may need to continue over time, but not just at the moment of diagnosis, meaning the conversation needs to be continued throughout the journey. To conclude, our work suggests that among young women with cancer, birth control use may shift around the time of diagnosis, but overall, we can see that it tends to decrease over time. The main message is that there is still an opportunity to better integrate reproductive health support into cancer survivorship care, for example, birth control, counseling, and patient-centered tailored contraceptive care. And with that, thank you for your attention. I'll be happy to take any questions.
Thank you so much, Ivy. Up next, we have Vincenzo Melo.
Hey everybody, my name is Vincenzo. I am a PhD student at the University of Washington, and I'll be presenting today on a recent publication using All of Us data titled Investigating the Relationship Between Social Support and Healthcare Barriers Among Sexually and Gender Diverse Young Adults in the United States. And I'd like to start by just giving a shout out to my co-authors, Vaughn Armbruster, Treashout Hawkins, Stephanie Tillman, Javon Carter, and Megan Lewis, as well as thank the All of Us participants who participated in the program, thus making this study possible. So to give some background, sexually and gender diverse young adults experience a lot of different barriers that prevent them from accessing healthcare. This may include policy barriers, structural barriers, as well as just personal barriers related to stigma accessing healthcare services. But despite all of these gaps, there are very few programs in the US that actually look at how health systems can support sexually and gender diverse young adults navigate these barriers and access the care that they need. And additionally, there are a few data sets that exist that allow researchers to be able to look at these barriers and identify what might be next steps to creating solutions for better engaging sexually and gender diverse young adults in care and making sure that they have this important access. So that's where this study comes in. So in our study, we aim to explore how informal social support among sexually and gender diverse young adults was associated with reported delays in healthcare access in the past year, as well as discrimination in healthcare settings. And the goal of this was really to inform what types of support are important for when folks are accessing care, so that structural factors and structural programs in healthcare systems can then take advantage of adopting program services, et cetera, that really cater towards these types of support. So next slide, please. So I mentioned our research objectives. In our study, the main exposure that we looked at was the medical outcomes study social support scale. And this is asking folks different types of support that they have on a scale of none as a 0 to all the time as a 4. And this includes things like having somebody to take care of you when you're sick, having somebody to transport you to the hospital when needed, etc. And our outcomes of interest are reasons for delaying care. And you can see there's these 9 reasons, things like transportation, having to pay out of pocket for some of the procedure, getting time off of work, being nervous to access a healthcare provider, as well as discrimination in medical settings. And these include questions related to being treated with respect, receiving poor service, and other biases that folks may have experienced in a healthcare setting. So what we used the All of Us controlled tier data from version 7, and we created a sample of sexually and gender diverse young adults ages 20 to 35 years old who completed all relevant questions. For our statistical analyses, we conducted hypothesis tests comparing reported healthcare delays, discrimination, and social support by different participant characteristics. And then for our main aim, we conducted 2 multivariate logistic regressions for each outcomes, with one controlling for emotional support and the other controlling for instrumental support, respectively. And we also controlled for age, gender identity, race and ethnicity, annual income, and housing stability. Next slide, please. So the graph on the top right illustrates the findings from our main analysis. So we can see that given that the adjusted odds ratios are all less than 1 for our main outcomes as well as our main exposures, this indicates that social support provided a protective factor in this relationship. And then we also found some interesting findings too with regards to how certain variables related to these outcomes and exposures too. So for example, in the bottom right graph, we can see how housing stability was really disparate based off of the different outcomes that we see. So folks with greater housing instability were more likely to report discrimination in medical settings, as well as more likely to delay care, illustrating a gap that needs to be addressed moving forward. Next slide. So in conclusion, our findings really illustrate that there are a lot of different barriers that sexually and gender diverse young adults have when accessing care. A lot reported delaying care, a lot reported discrimination in medical settings, but social support was shown to be potentially a protective factor that can be taken advantage of by health systems to improve access among sexually and gender diverse young adults to make sure that they're able to get access to the care they need. So once again, thank you, and happy to take any other questions.
Thank you so much, Vincenzo. I'm going to invite Yash and Ivy back to the virtual stage for some questions. If anyone in the audience has questions, a final reminder to just put those in the Q&A box on your screen. I want to start with a couple of questions for Ivy. What kinds of cancer did you look at specifically, or could you give us some examples? And did you consider hormone receptor positive cancers as a potential factor in the changes that you've observed to participants' contraceptive use?
So for the first question, in this study, I try to include any types of cancer, but when I look at the characteristics, top 3 cancers are thyroid cancer, colorectal cancer, and breast cancer. So that's the first question. And the second question, so for now, I didn't look at, we still haven't looked at potential factors for the hormone receptor positive cancer, but that is a good point. What our plan is to look at the treatment they're receiving, surgery, or other types of treatment. So that could also be a factor, but that is a good point for the hormone receptor positive cancers.
Thank you. A question for Yash. And first of all, congratulations on graduating recently. That's great. I'm curious, for the 2 surgical interventions that you looked at, are there specific patient conditions that might be driving who is getting these surgeries, and would that impact your results at all?
Yes, thank you so much for your question and your kind words. So I think first we had HoLEP and TURP. So the first thing I found is that HoLEP is used for larger prostates. So I would say more complex cases. Because if benign prostate hyperplasia, our prostate is already a little big. So the prostate is very big in terms of size. And second of all, since HoLEP is a neurotherapy, not all physicians are trained to do this surgical intervention. So fewer physicians are definitely trained to do it. So I think both of those things could definitely affect the results, because definitely you have to find a HoLEP trained physician, and there should be a need to do it, and then they go ahead and do it. But definitely the popularity of this therapy is definitely growing because of how effective it is.
Thank you. And one for you, Vincenzo. If housing concerns are a critical factor in receiving consistent healthcare or being comfortable with the healthcare that you're receiving, how does the young sex and gender diverse cohort compare to other populations like older SGD groups or non-SGD populations?
Yeah, that's a great question. And I think what we found in the All of Us data set was that relative to middle-aged or older sexually and gender diverse young adults, younger sexually and gender diverse young adults had the most concerns about housing stability, which really highlights the importance of addressing that topic in a younger audience. And then compared to other populations, when we consider how intersectionality plays into the different structural systems of oppression that impact an individual and their experiences, we really can see that for sexually and gender diverse folks who report housing instability, there are these worse reported outcomes compared to cisgender heterosexual counterparts. So it's really important to consider all these different overlapping identities, systems, and experiences.
That's great. Thank you all so much. We're now going to transition to the end of this session. I want to thank all of our panelists for sharing their work and for demonstrating the potential of using the All of Us data set. And thank you all to our audience for joining us and for asking great questions today. Please don't forget to vote for your choice for the People's Choice Awards for Science Day by 3 p.m. Eastern Time. For those of you not in Eastern Time, it's currently 1:42 p.m. So you have a little over an hour to cast your ballot, cast your vote through the Science Day webpage. There will be a short survey following this session. After completing the survey, you'll be automatically redirected to the keynote session, which is beginning at 1:45. And you can see more details about that keynote session on the slide here. We hope you all can join us. And thank you so much for joining us today.